Ani hostu. Good morning, good morning, good morning. My name is Florence. I'm trying to click where I can join with the video. You're welcome to CIU. I can see we are 11 people. As members join, we can give people like the next 5 minutes before we go ahead. I recognize our speaker are already in the room. We also have our VC in the room. We have our management team. We also have our Dean, Madam Agnes. My name is Florence from the Quality Assurance Office. I'll be the moderator for this session. I'm just giving members briefly 2 minutes because it is coming to 10:05. We agree that we give them the next 2-3 minutes, then we start the session. Okay, our time has clocked 10:06. We can get on. My name is Florence Gidinji. Like I said, I work in the Quality Assurance Department. I would have liked my video to be on, but I've tried to switch it on here. I have failed. I apologize for that. And I want us to know that this is the BCAM month, that is the Breast Cancer Awareness Month. It's October, where we learn, where we connect, and where we act towards, and also we reflect on the entire on cancer, that is breast cancer, for the entire month. We are privileged to have people who have gone through this journey, and We are going to hear more about that. But before we welcome the people who are going to talk to us about that, or the person who is going to talk to us about that, I want you to welcome you to all to CIU. I want to recognize our senior management again. I want to welcome our VC. I want to welcome our speaker who is going to talk to us later. For now, I take this chance to welcome our VC, Professor Rose Clark, who is going to talk to us, just give us an opening remarks for this meeting. Welcome, our VC. Okay, maybe Madam Shamira, you could check out with the VC, because according to the program, she will give her remarks. She can give her remarks later. We can go ahead and welcome Madam Agnes, who can just give just an opening remark, as we when after that I will introduce the speaker of the day. Just welcome members, Madam Agnes.
Thank you, Madam Florence. Good morning, everyone. You're most welcome to this webinar. As you are aware, we are closing out on the breast cancer month, and being a health sciences university, we really prioritize information sharing amongst ourselves and with those that are experts. So would like to welcome you to this particular webinar, and I'm very positive that it will be a great learning platform for each one of us, with new knowledge, new experiences, and enriching sharings. I must appreciate the presence of our guest speaker, who will be introduced to us by the moderator. And I know that by the end of the session, we shall not be the same as we came in. And I believe that will be an empowering message for us to become torchbearers for cancer-related activities, whether in our workplaces, in our families, in our communities. This will be a point at which we are able to become ambassadors in creating awareness and instilling hope among individuals who are affected by cancer, or who have defeated cancer and moving positively with it. So I would like to hand over to the moderator and say you are all most welcome, and please take keen of every communication that comes on, so that we become change agents wherever we are. Thank you so much. Back to you, Florence.
Thank you so much, our Dean, for that elaborate welcome. And We know Madam Gertrude is in the house. I wish we could clap for you, but I know there are emojis for clapping. I thank you for coming. Let me just introduce Madam Gertrude. Madam Gertrude is a co-founder and Chief Executive Officer of Uganda Women's Cancer Support Organization. She bravely defeated breast cancer, 21 years ago, and now developing cancer advocacy awareness campaign and patient support program. Gertrude is a member of the board of directors of Uganda Cancer Institute, member of Patient Advocacy Committee of Advanced Breast Cancer of the European School of Oncology, working to improve survival of breast cancer patients. She is a graduate of Awareness Association for Cancer Research. So we have a very senior person with us who has gone through this experience. I know Madam Gertrude was supposed to present with another lady called Madam Margaret Nanteza Okello, who has sent her apology. She is hosting a dissemination session. So Madam Gertrude will have a big load that she's going to give us in the next few minutes. First is understanding breast cancer, an overview and statistics. Then we shall hear her personal story. We shall also get the reasons for support and navigation process in that support, coping strategies, which include the policies and also mental health, which is going to be a very heavy session. I like it that we even have gentlemen here, so we have all genders, because I know people are embracing breast cancer awareness, whether male or female. I thank you and I welcome you, Madam Gertrude, to give us this elaborate presentation. Thank you.
Thank you very much, Florence, for the warm welcome. And I also want to thank the VC and senior management for the opportunity to share with you my personal experience, but also my cancer work, especially in this month of Breast Cancer Awareness Month that we are concluding today. I think I beg to switch off my video so that I don't get interruptions maybe with the internet, so that now that you have seen who I am, I'm not a robot. This is how I look. So I would like to switch off my video so that I can share my presentation, if that is acceptable.
Yes, we have seen you now. You know it's not a robot. I'll try to work on mine and you also see me. Yeah, thank you. Go ahead.
So thank you very much for the opportunity. I want to share with you navigating breast cancer, a life-changing experience. And I've already introduced myself. So our conversation today is going to be, I will share with you what WUCASO is and what we do. I will give highlights about breast cancer in Uganda. I will give cancer survivors patient experiences and some of the interventions and navigations that we are working on. And then we shall also have a highlight on the breast cancer policy landscape in Uganda. And then we shall have question and answers. WUCASO, Uganda Women's Cancer Support Organization, was founded in 2004 by breast cancer survivors, and I'm one of the 5 people who were there when it was founded. It's a membership organization of survivors, but also we have a membership of other well-wishers, the associates. It's governed by a board of directors and advisors. We have a secretariat in Kamocha with the staff, 5 full-time staff, and we have a network of volunteers who are more than 50 and are survivors and are across the country. WUCASO is a member of Uganda Cancer Society, is a member of the Union for International Cancer Control, UICC, is a member of Africa Cervical Health Alliance, that is ACHA, and WUCASO is a member of ABC. ABC is Advanced Breast Cancer Global Alliance. So that is about Okaso, and I think in the picture you can see some of the beautiful survivors and the fighters of cancer. Breast cancer in Uganda, this October is Breast Cancer Awareness Month, and we all know that we join the rest of the world to increase awareness, but also to commit ourselves and make our commitments to support both the patients, the survivors, and the work of breast cancer in all spheres. In 2022, breast cancer ranked number 2 in women and 3rd in all cancers that were diagnosed in Uganda. So it was close to 3,000 new cases, and 1,560 people died of breast cancer. I think this now was a wake-up call for us as Ugandans to know that breast cancer is a real problem in Uganda, because losing over 1,500 people to one disease, to one type of cancer, which can be prevented, which can be cured, because breast cancer is one of those cancers that are treated and cured. I believe 22 years when I was treated for breast cancer, I believe I cured, because for the last 16 years, I'm not on any treatment, but I don't have any trace of disease. So we do all this to make sure that we improve survival, and also we control we contain the disease as early as possible. Breast cancer has no cause, but it has risk factors. And I know I'm talking to the converted, because I'm talking to people in the School of Health Sciences, but this is for emphasis. There are risk factors that put us to develop breast cancer. We have what we call modifiable and non-modifiable. Non-modifiable risk factors are those that put us on a higher risk, and we don't have a lot of control over them, but we should be aware so that we avoid those which we can avoid, so that we reduce our risk. And this is from Uganda Cancer Institute. At attained height, the taller a person is, the greater his or her risk of breast cancer, because of the rate of growth and the hormonal levels. But also there are other evidences, such as genetic makeup. Some people are born with a type of gene that increases their risk of developing breast cancer. Without checking the genes, but we have seen their families, that more than one person developing breast cancer, most likely that family has a gene. Personally, my own father succumbed to breast cancer, and I got breast cancer when I was 28 years. So probably I carried the gene. I haven't had the capacity to check whether I carried the gene, but I've also had a number of family members who have developed breast cancer. Also the age, the older one becomes, the more likely she or he may develop breast cancer. So there's nothing we can do about our age. However much we try to remain young, normally as women, we cut our age, but nature will ensure that your age advances, and we should be aware that the older we grow, the higher the risk of developing breast cancer. But it's also important for us to note that in Uganda, breast cancer is normally in young women. And I think those of you who are in healthcare, you will realize that there are a lot of young women getting breast cancer. I got my breast cancer in 28 years. And we see a lot of those in their 20s and their 30s, and the mean age is 40 years. So you can imagine, whereas we talk about the older, but here we have a lot of young women developing breast cancer. So it's important for us as people in the healthcare fraternity to know that breast cancer is more in young women. Early menarche, when people getting their menses before the age of 12, or late menopause, getting your menopause after age of 55. So the body has all that time exposed to hormones that may be responsible for breast cancer. Also, when we go to another part, there are some factors that are modifiable, what we call modifiable risk factors of breast cancer, and these have strong evidence. Delay in having the first pregnancy,
women who have their first pregnancy beyond the age of 30 have an increased risk. It doesn't mean that when you delay having babies, you will have this, the risk increases, especially when you have other risk factors like the non-modifiable factors. Not breastfeeding. Women who do not breastfeed their children or their babies have a higher risk. So that means if you delayed having your pregnancy, you have had the pregnancy, you may have had your baby at the 35 years, you have not breastfed, you have a family history, the risk even increases higher. So this is a combination of factors that may increase your risk. Being overweight. We are seeing a lot of people getting overweight because of the sedentary life we are living. We drive cars, we move in lifts, we never walk. So people have developed, and even the way we eat most of the time Western food that accumulate a lot of fat, which fat is not burnt. And we're not doing enough vigorous physical activity. There are no activities. The smallest activity you do, you walk from your office to your car, from your car to your house. So there is no vigorous activity. So we encourage to do vigorous activity to reduce our risk. Alcohol consumption, there is an increased alcohol consumption. I think Uganda ranks among the highest consumers of alcohol. There are a lot of young people consuming alcohol here, both girls and boys. So this increases the risk of breast cancer in their lifetime. Tobacco use. And also we are seeing a lot of increased use of tobacco in all its forms by young people. And young people start as a fashion, but by the time you realize you've increased to breast cancer, but also other health conditions like heart disease and diabetes. Exposure to radiation, if somebody is exposed to radiation such as X-ray, during X-rays during their lifetime, also increases their risk of breast cancer. Medications such as hormonal therapies, I think as health workers, as we prescribe some medicines, I think bear in mind that some of the hormonal therapies increase the risk of breast cancer, especially when somebody carry other risks that we've talked about. It's also important to note that breast cancer is also in men, and I'm happy that there are men on the call. Globally, it's about 1% of breast cancers. It's in men, but in Uganda, it's as high as 4%. So the men are also at a higher risk of developing breast cancer. And I've already shared that my own father died of breast cancer, but he died after me. I got a diagnosis far before him. And when he developed breast cancer, we didn't know because we didn't think a man would develop breast cancer. And until he saw a wound, until the itching became a wound around the nipple. And by the time we were going to hospital, the cancer had already moved to all the parts of the body and only lived for 3 years. I also wanted to share with you some of the signs and symptoms of breast cancer. But normally we encourage that you don't wait to see some of the symptoms, some of the signs that are obvious. Now that we know, if you know you carry a risk, or you know you're a woman and a man, and you are maybe, because now we cannot say any age. I mean, we cannot say when you're old. As long as you're a woman and you have a breast, you have time to have your breast checked. But some of the signs that you do see when you see the extreme left, the normal breast, the nipple is okay, the skin is smooth as the rest of the body. But when you go below, you see dimpling like an orange peel. That one is not a good sign of a breast, because that one of the indicators that it may be inside breast cancer is developing. There is a nipple retraction. The nipple tries to pull inside, and that one also is not a good sign. There is also unproportional breasts. One breast is bigger than the other, one is fatter than the other. Then we have also breast ulceration. The breast starts getting ulcers, it starts getting a wound. So that wound, I mean, it's not healing. Some women in the community see the wound not going, not painful. And by the way, at all this stage, the breast, nothing, there's no pain. There is a swelling in the armpit and you don't have a pain, and the people live with these things because they are not painful. So until they have a pain. So, but we shouldn't wait to this level. So I think as health workers, if you encounter with any lady at any one point, mention that they should be responsible for their breast. They do breast self-examination, check to make sure that the breasts remain normal, so that in case of anything, the breast comes out, then the person is able to tell and seek care. I want also to share with the survivors' experiences and interventions. Some of the experiences that we face when you get a diagnosis is fear of death. I think in most cases, cancer news is a death sentence. So even if you survive, you feel the fear of death still, the bell rings in your ears. So I think patients need a lot of support to overcome that fear. There is anxiety and restlessness. There is self-isolation and mood swings. Some people will decide not to talk to others. They will isolate themselves. They will be moody and you may not know what is going through their lives. There are a lot of suicidal thoughts. I've highlighted the suicidal thoughts because some people may not mention, but as we interact with the patients, we always see them. They share with us they want to end their lives because they feel they are not useless. I mean, they are not useful. So it is really important that mental health is a part and a parcel of the care that is given to patients, not about chemotherapy. Because when the patients go to the hospitals, how the drug is working, what are the side effects, but they are not talking about the mental well-being of this person living with the disease. There is loss of self-esteem due to surgery. I mean, as a woman, when you lose a breast, the community takes you as a half woman, as somebody who is not full. So the self-esteem for women goes, people don't want to go back to work because how will people look at me? How will I go to parties? So that's that the self-isolation comes in. The stigma, people are stigmatized at all levels, whether in high offices, in the communities, people with breast cancer are stigmatized. So people keep it to themselves. So that's why they need a lot of support. There is loss of libido and fertility due to treatment. So chemotherapy especially and some hormonal treatments affect the functionality of women and the men. So and this as a health worker, I think now you interact but you do at the back of your mind, you should know that these past people will be dealing with loss of libido, they'll be dealing with the fertility. I mean, if you get cancer at 30 years, you have not had a child and you've lost your fertility. So, I mean, in Africa, we believe in children. So if you have not had children, then you are not a woman. I want to say, luckily, I got a child after my cancer treatment, but many women are struggling with infertility after cancer treatment, and they are really young, and they are young couples. And then what comes in is the spouse abandonment. The spouse will leave you because you're not going to give a hair, you're not giving the people to support to take the lineage ahead. There's a difficulty in accessing artificial breasts and special bras. Because breast cancer is treated, one of the modalities is mastectomy, removal of the breast, either one or two. And these artificial breasts are not available. And if you use a piece of cloth, you need a special bra. Otherwise, the cloth will be jumping out, and then people would wonder what is happening to you. One time I shared with a police officer, she went back on duty and then the piece of cloth fell out and everybody made fun of her. And she was at one of the big offices at the entrance. So people made fun of her. She almost resigned her job. So there is loss of employment. We have also witnessed a number of employers terminating patients because the treatment takes so long and some of the employers are not patient enough to keep people. But when we survive, we are productive like any other person, but people don't know. So we need to tell people that breast cancer is not the end of life. Once they are treated, then they can be useful and work again for the nation and the development of their communities. Another challenge is the centralized treatments. leading to accommodation, food, transport challenges during treatment. I think we're all aware that the treatment center is only one in Uganda Cancer Institute. The comprehensive treatment is in Uganda Cancer Institute. So patients will move all the way from all the parts of Uganda, including the neighboring countries. So accommodation becomes a problem. You will find a lot of people in the corridors of UCI, on the verandas, in Kamocha slums, and they have no food. I think you even see some on the streets fundraising. The transport coming every time. Cancer treatment takes long time. The aggressive treatment is at least 1 year. So in 1 year, somebody has to make several journeys, come for chemotherapy every after 3 weeks. So they can't afford it. Not every Ugandan would afford those several journeys and the upkeep in Kampala. So these challenges are only known to the patients, and because there are no psychosocial support services for the patient. So once they come once, they find life so hard in Kampala. When they go back, they don't come back. And they only come back when it is too late. And then the health workers will start blaming them. Where have you been? Why didn't you come back? Do you mean you've delayed? But there are a lot of things that are happening in their lives. They cannot sustain their lives when they are in Kampala. They cannot afford the transport. They are dealing with their marriages breaking in the communities. They are dealing with the language barrier when they come here, because not everyone who comes to Kampala can speak Uganda. People come from different parts of the country with different languages, with different cultures. So they go back, and then we put the statistics that, 90% don't survive. But maybe they don't survive because of the structural challenges. Also, another challenge is the high cost of radiology services, radiotherapy, and surgery services. It's unfortunate that the radiology services are not free. The scans, and cancer treatment, you need a PET, you need the CT scans during the treatment to see whether the drug is working, whether cancer spread, and not many Ugandans can afford these services. Radiotherapy is only in Kampala, where everybody comes in. So even if it's provided at a subsidized price, but even the cost of maintaining a patient in Kampala on radiotherapy, because somebody has to go in every day, have 35 sessions, and those are 35 days, Monday to Friday. So you can find somebody has to be here for 3 to 5 months, and this maintenance becomes a challenge. And also surgery services. I think if I don't know how we can advocate to surgeons. The surgery of mastectomy is the most expensive surgeries. We have a surgical department at UCI, but the line is so long and the patients are so many. If we get 3,000 new cases every year, how many surgeons do we have? So I hope the university is training some surgeons so that maybe you can increase on the workforce. And what are some of the innovative approaches we have done and the navigation? What we have done, our partners, Cancer Aid Organization, they've started knitting artificial breasts so that women can access them at a very subsidized, if not free. Because at least when you get something to put in your bra and then walk, you are a woman again. We do home visits. We go to the communities. I think I'm in the extreme right. We go to the communities, we go to the homes and visit these patients. At times we move as a team. We move with a psychologist because now there is a mental challenge. We move with some men. We've trained some men champions because we need to talk to husbands and then a survivor. And this will realize it has really worked. We also have counseling at our office. Patients come in and we do counseling and we support them and we guide them. But also we do navigation at Uganda Cancer Institute. I think when in the lower corner, you see the survivors wearing a green apron. Now UCI has given us a uniform. We wear a green apron to help these patients navigate through, because Uganda Cancer Institute is very confusing. When a patient comes in, you need to register, move to one place to the other. So our team of survivors work with the social workers and navigators to talk to these patients, ensure, of course, give them hope, but also ensure they reach the places that they need to go to. Because they said you go to radiotherapy and you are downstairs, and then when you go there, then they go to the records. So it is very difficult for these patients to access these places, and most of the time they give up all their cheated by wrong people who stand in the corridors to take advantage of them. So the survivors come in to bridge this gap, but still we only do 1 day in a week because it's not sustainable. You have to give these people lunch. You have also to give them some moderate transport, but also we've got a mental breakdown of our own survivors because the challenges of these patients are too huge that you talk to a patient, you also feel you are soaked in their problems. They've come, they lost, I mean, they don't have transport, they don't have food, and you cannot provide all what they are requesting for. So you also break down. So we also have a breakdown of the patients and the survivors. But also you can see in the lower corner, we also do some physical exercise and wellness programs. We call them peer sessions, where we do exercises to support the mental well-being. Because we realized some people come when they are sad, when they are drained, but we also have a day where we do physical exercise, we share, we play, we dance, and we have as a place in May where we will put a tent and then support them. I wanted also to share a breast cancer policy landscape in Uganda. This goes back to in 2021, World Health Organization established a global breast cancer initiative, GBCI, and it was a convening meeting with all the WHO and UN partners to bring together stakeholders and encourage them to work to reduce the burden of breast cancer, because during that year, breast cancer became the leading cancer in the world. Breast cancer was #1 globally. And that is a challenge that we need to address as individuals, as universities, as institutions, so that, because we know breast cancer is one of those cancers that can be successfully treated, but also we can prevent it, or we can catch it early through different interventions. So WHO was encouraging all institutions or countries to have strategies and interventions in place that can reduce the burden of breast cancer in the next 20 years. So in Uganda in 2022, Uganda experts from Uganda Cancer Institute, Mulago National Referral Hospital, Makerere School of Medicine, College of Health Sciences, and UKASO and other civil societies, we convened and then to develop the first Uganda breast health care guidelines. Uganda has a breast cancer treatment guidelines, but it's only talking about treatment. So these experts came together with the support from experts from University of Washington and the WHO to have a comprehensive guideline right from the lowest level to the highest level. And then we came up with the 4 pillars in this guideline. We have the primary care pathway. In the primary care pathway, it's what happens if somebody identified a breast problem at the lowest level, at a VHT level. What is the role of a VHT? Where will the VHT, what the VHT do, and where will the VHT send this person? Because we already have these structures existing. If somebody is at health center too, and a woman came with a breast problem, what can she do? So that is what we have in the primary care pathway. We have a diagnostic pathway. And if somebody is in the diagnostic, either an X-ray person or a scan, all these people, what is their role? Referral, not to delay people. And the treatment and the palliative care pathway, what is supposed to be. So this one is now combined with the current breast cancer treatment guideline. And then we added on the policy and the advocacy pathway. So I'm happy to let you know that I'm the co-chair of the policy and advocacy, writing that bit. But also this guideline has been reviewed by the senior management at Ministry of Health, and it has been approved. And we are now working on the final document, We wanted to have it out by this October, but we are late because now we are working on the design. We've just had the ministry give us a green light to go on and then have it designed and then finally launched. So I think it will be, we have a dissemination plan. So we shall have it read by, shared by the universities and people so that everybody knows what is their role in breast cancer prevention, in breast cancer management, so that we don't see these women dying. In the developed countries, we have 80 to 90% of women surviving breast cancer in the 5 years. Here it's only 56% survive for 5 years. That is low. And so many women die there not because of their own fault, but because of maybe the system. Somebody saw this person but don't know what to do. If a person came to your university and you've interacted with this person, what can you do? So this guideline is going to help us to help on the referrals and the early detection and the information. I also, in terms of policy, I want to let you know that we have a Uganda Cancer Institute Act 2016. It was passed in 2016. And this act mandated the Uganda Cancer Institute to be the whole institution in charge of cancer control and the cancer management and the control in terms of research, in terms of training, in terms of treatment. So all these functions are done by Uganda Cancer Institute on behalf of the Ministry of Health. So and in this act, there is a provision. There must be a representative of the patient community, the civil societies. And as Florence introduced me, I sit in the board of directors as a representative of the patients and the civil society community because of the act. And also after this act, the East African community gave Uganda the honor to be the East African Center of Excellence for Oncology. So in East Africa, Uganda is the Center of Excellence. So we get a lot of referrals for treatment, and also because it's a Center of Excellence, and now it has training programs, fellowships, and I'm sure maybe if you are not yet the VC, maybe you can seek for partnership and see how the students that at this university can benefit from some of the training programs. Because our biggest challenge is staffing, human resource, from nursing to the highest level. But I think many people have not taken interest in oncology and to work to support this work. So I think with that, I want to say thank you very much for supporting our efforts to give hope. This is one of the picture of the ladies. These are only breast cancer ladies at Uganda Cancer Institute. We also do a peer session every Thursday at the care home, and that they were distributing the breasts and artificial breasts and special bras. And you see these women lose hope. Some of them have fear even to go back home because they are being told not to come back. They curse their families. So we need to give them hope, but also we need to go to the community and educate the communities, but also talk to their families to ensure that these people are accepted and not stigmatized. So we still have a lot to do and we cannot do it alone. Thank you so much for the opportunity to share with you. I will be able to answer questions now.
Thank you so much. Thank you so much, Madam Gertrude. We couldn't ask for more, but I know we are going to ask for more through questions. I can see you already have one question on the chat. And we have heard so much. We have heard from the diagnosis to the story, to the support, to the policies. And you are invited to ask any question. You can put your hands up as I read this question and Madam Gertrude gets on it. Then we can have any other questions after that. So one thing someone has asked here, could you please explain to allay the person or patients what to expect in hospital when I'm told that I need primary care pathway, diagnostic pathway, etc.?
The primary care pathway, this is going to be a guideline breast health care guideline has sections. Primary care pathway is at a community level. If, for example, you're working at Health Center 4 in Katakwi district, and a lady came in with a breast problem, a swelling, or one of the signs I've shown, this guideline will show you what to do, but also it will show you which pathway to send this person. Sometimes that people at the lowest level don't know what to do. At diagnostic, if you are managing a scan or an X-ray, it will guide you on the reporting. How do you report, and the whom and the where do you send this person? If somebody sent somebody for a scan to you, do you want to give the results to the person, or you send the results to the sender? We are advocating that instead of breaking my heart, oh, I have seen cancer when I did this X-ray, prepare these results and inform my clinician so that the clinician is able to give me my results with a counselor around. I don't know whether I answer her question.
I think so, because I've not seen another question from the person. First of all, we would want also to ask you, Madam Gertrude, how did you fight this? How was your story? And before you come in, I have my co-host, who is Vivian, who is going to take through the QA session, and also want to recognize the presence of our Vice Chancellor, Professor Rose Clark. I believe she's going to give her remarks when we end this. I will hand over to Vivian, who is my co-host, as we are listening to the story. How did you manage to overcome this fight? Thank you.
Thank you so much, Florence. Of course, the story was a heartbreaking story. When I got a lump in my breast, I didn't know what it was. You know, at that time, I was developing my career, thinking about family, never think about cancer because it has not happened in my family. And when the lump came, I looked at it, I ignored it, and I left it for almost a year. And then, but it was growing. So just by irritation, I took it to one of my primary care provider, and then he said it will be removed. And then they sent me to a surgeon. The surgeon removed it. And of course, the surgeon broke the news that it was cancer. Of course, it was very hard to contain because that's something I never expected. And then the way he broke the news was casual. I mean, this thing that we removed had cancer. And of course, it took me a month to get back to my senses. I would walk on the street crying. Whoever I would tell, people would switch off the phones because they didn't know what to tell me. So it was a nasty experience. I didn't know where to get the services. I went on to the private hospitals. Went to the bank, withdrew. I had just got a job, withdrew my salary and put it in my bag. So I would enter in a clinic. Of course, you pay consultation. Then somebody doesn't know what to tell you. Then until when the money was finished, I went to Mulago. That time, Cancer Institute was still the department of Mulago. And that's how I started my journey. They told me to remove the breast. They removed the breast. It was also everything that happened to me was a shock. I had never seen anyone without a breast. And when I asked my surgeon, he was not able to show me a survivor. So I went into something I didn't know. I thought they would scoop out the breast and leave the heart out. Because even my family was scared to take me to hospital. My mother thinking that when they remove the breast, the heart will be out and there will be no cover for the heart. So I also went to remove the breast, but I didn't know what to expect. And the surgeon couldn't explain it to me. So, I mean, when the surgery was done, I said it was a scar. I was happy. Then I went for chemotherapy. Nobody explained to me what it was. The hair fell off, so I wasn't expecting it. So everything that came through my life it was a shock, and every experience. So I think with other 4 people we had the treatment, we decided to say, no, now that we've gone through this, let us come together and support others who are going through it, because people get challenged along the way and they get diverted. And we see it today, even if we are there and we've been supporting people, but we see a lot of women have been diverted, but because they don't know. And also the people who are telling them don't know. So they will scare them. When you go for chemotherapy, you'll die. When you go for surgery, you do this. And the people delay. And they will delay because of information. So I use my personal experience to support others and also to make sure that these barriers that have been affecting people to receive care timely are not there. Because some of the patients are scared by health workers. You go to the health worker and then the health worker tells you, hey, will you survive chemotherapy? Then somebody just runs away. So that's why I'm really a part of the guideline to ensure that even the health workers are educated also to how to communicate to patients, because even the communication alone affects the patient and their mental well-being. So the story is so long, but I'll break it for more questions.
Okay, thank you so much, Madam Gertrude. At the moment, I want to encourage people that have attended this session to kindly register in the chat. Yeah, we shall have a running list for where you can put your name. And as well, we have another question here. The same person who asked the previous question is also asking that, can you please highlight some up-country centers that are first stopovers for patients up countries, more so in northern Uganda?
Thank you so much. What I had forgotten to let you know that government has put up 4 regional cancer centers. And one of them is the northern region in Gulu. It has started functioning to some levels, at least some diagnostics are there and chemotherapy. And the Arua, but those are regional centers, Arua, to some level of screening and a referral. Mbarara is also functioning, giving chemotherapy, admissions, but they refer patients for radiation and other specialized care in Kampala. And in Mbale, they've started the construction, but also maybe within a year, we should be having some services running. But it's up country. I think the health system has a system from center 2 to center 3 to center 4 to the district to the regional. So I think referrals are done that way. So the regional centers will be able to refer patients to their regional cancer centers. The eastern region will be using the Mbale region, then the northern will be using Gulu Regional Cancer Center and the Arua, and then Mbarara. And then Uganda is the national, there's the Uganda Cancer Institute with all the comprehensive services, including radiation. Radiotherapy is only given at Uganda Cancer Institute. But also we have a private center in Zambia. Zambia is giving cancer treatment, and they are, I think some of your Rotarians have been fundraising for the radiotherapy in Zambia.
Thank you so much, Gertrude. Another question over here. How much would radiology cost and how long does it take to complete the radiation treatment?
Radiotherapy is given, the doses determine how long, but the doses are given according to the disease, the type of cancer, but also according to the stage. There is radiation giving for palliative reasons. If the wound is I mean, like the breast is rotting and there is too much pain, there is radiation given to alleviate pain, and then maybe to reduce on the other symptoms. The cycles will be fewer, maybe 5 sessions or 10, but there is also radiation for curative reasons. The cancer, you've had your breast removed, and then they feel there were some smaller margins, and if they are radiated, they will eliminate cancer. They give you sessions, maybe 15 to 20 to 25. So the team assesses the number of sessions you need depending on the condition. And also the cost will also depend on the sessions given. But now we used to have a cobalt machine, which was using cobalt, which is outdated. So now Uganda Cancer Institute has purchased linear accelerators. So linear is more advanced technology and it's more expensive. The cost is between 500,000 and 1 million. But assessed, still, as I mentioned, they assess and then see how many sessions one is going to get, and then they determine the charge. But Uganda Cancer Institute has a waiver policy. So now during our navigation program, when we see the patient even has no transport, even has no food, we hand over the patient to social workers. They do the social assessment, and then people are given waivers accordingly. There are those who get 100% waiver. There are those who get a percentage of the waiver. Only that, as I mentioned, that there is a lot of misinformation everywhere. And because there are so many patients, there are also wrong people in the system. There are people who take advantage of patients because they have no information, and they will take money from the patient before even they reach the right person for treatment. That's why we need more men and more women on the job to navigate the patients, to give information at all levels, so that we can eliminate those loopholes that people use to take money from patients.
Okay, thank you so much. We have one last question, and the Vice Chancellor will also come and give her closing remarks. As for now, I still want to encourage, continue registering your names for attendees over the chat. The last question is, what is the color of discharge from the breast? And does it flow out freely, or one has to press it out?
It may not have a specific color of the discharge, but normally it may be a watery discharge, it may be a bloody discharge. But what I want to let people know that not every discharge in the breast is breast cancer. So in the guideline we are working on, we are looking at breast health. Whereas there is breast cancer, but there are other breast health conditions that needed to be addressed. So that's why you need to seek care. You go to an expert and assess the discharge, assess the swelling, so that you are not also misdiagnosed. So that the guideline will train health workers also to identify what is correct, and if they are not sure, where do they send this person.
Okay, thank you so much. I hope that discharge is clear. It can range from colorless to bloody and maybe other colors. So one last important question here for the men. They are saying there is a myth out there that sucking a breast helps with curing and prevention of breast cancer. Madam Gertrude, is this true, or it's just a myth?
I think it's a myth. When we talk about sucking, we are recommending breastfeeding, because when you have a baby, the body naturally prepares the milk, the hormone is at work. But when the man is sucking the breast, it's not related to the breast milk. So I think now that this is a university, we can write a proposal and do some more research. But I would think it is a myth, but it's also good to also research and see whether it's true or not. But I've not come across any publication talking about that.
Okay, thank you. As for me personally, and someone also using a gadget called ASA, they're like, can you throw some little emphasis on the men to know that, do they also get breast cancer? Are they equally affected? What is your take on that?
Yeah, the men get breast cancer. It is true. And as we talk to the women, we should also let the men know, especially those who have a family history. I shared that my family, my father died of breast cancer. And we see even in our group, our survivors, we have 2 breast cancer survivors who are male, and one of them is 27 years. So breast cancer affects both the men and the women. So the men should also be cautious and take care, avoid the things we talk about, but also do screening, check their breast regularly, so that they also, if they have any signs, they are able to report them.
Okay, thank you so much. There is a registration link over the chat. You can tap the link and register your name. Thank you. At this point, I want to invite the Vice Chancellor to give her closing remarks. And thank you, Madam Gertrude. Thank you so much. We have really learned a lot. I request the VC, Clark International University, to take over.
Thank you, Vivian, and thank you, Madam Florence Gisenji and Dean Agnes Agwang, the School of Nursing, for organizing such an important interaction this morning. Special thanks to you both, Madam Gertrude and Miss Margaret. It's really good to see you again, or at least hear you again this year. We kept our promise when we saw you last year here on the CIU grounds, but also in Mulago when we met at the Cancer Institute. We promised we would invite you back, so you should become a resident teacher here on all things breast cancer. Thank you for sharing your powerful stories of suffering and of recovery. I know that millions of women, not just here in Uganda, but globally, suffer from breast cancer. I know that as we were having this conversation this morning, several more have been diagnosed with breast cancer. So I hope that your work can continue to light a path for all of us, especially those students who are clinicians who are graduating and are soon joining the workforce. Being able to screen, even though most studies indicate that the earlier you screen, the better the outcomes, we know that women are still not screening. We know that daily practices at home, the self-breast exam are not routinely done, even when women actually have knowledge and they know how to undertake that exercise, that many women still do not. And therefore, we continue to have women discover breast cancer when it is already too late. So I would like to encourage all my colleagues online to really heed the advice of these two practitioners, to continue to not only raise awareness, but also establish a pattern and a framework that allows you to do the self-breast exams. And I also heard Gertrude say that, you know, men do get cancer as well. So the self-breast exam is also true for men to engage in these practices. October is Breast Cancer Month. We hoped to do more than what we have achieved this month, but I hope that you can join us again next year in this campaign and in these efforts to continue to give hope, as you so rightly put in your last slide this morning. So thank you very much to you, Ms. Gertrude. Thank you, Madam Margaret Nkelo. Thank you for giving us of your time and for adding value. And to all our audiences who attended the webinar, thank you for showing up this morning. Back to you, the moderator. Back to you, Madam Florence and Vivian. Thank you very much. God bless.
Thank you, everyone. Thank you for coming. We hope to see you.
You are muted, Vivian.
Sorry, we want to take a screenshot of the attendees. So you can please wait to log off. Let's take a screenshot. So for now, let's first take a screenshot for the attendees. But now some of you are using your gadgets and we cannot tell who is participating here. So we require that maybe you can tap that link in the registration chat to register. Yes. Okay, thank you. You can also turn on your video so that we can take a screenshot as well. Okay, let's all turn on our videos so that we can take just one screenshot at once. Yeah, Mr. Arnold, just take a screenshot at once. Okay, that's done. Thank you so much. Thank you, Madam Gertrude. Thank you, our admins and the rest of the team. Have a nice day.
Thank you. Bye-bye. Thank you so much, Gertrude. And
Thank
it was
you.
listening to you. And we appreciate the time that you've given us, and we will continue collaborating with you as
My
CIU.
pleasure.
Yeah,
My
we'll
pleasure.
see you soon.
Thank
Bye.
you. Bye.